So good afternoon, good morning, good evening, everyone, to this organized session on initiatives to enhance the accountability and responsiveness in publicly funded health insurance programs, learning from multi-country research program, organized by the Alliance for Health Policy and Systems Research in collaboration with the Department of Health Governance and Financing, WHO. I'm Zubin Shroff, Technical Officer at the Alliance for Health Policy and Systems Research, which is a unit within WHO that seeks to stimulate the generation and use of evidence to strengthen health systems in low and middle income countries. And with me here are four presenters who will be, three of whom will be presenting on their reflections from research programs that they are working on as part of this larger research program of 7 projects. And also we have with us Inka Mathawa from the Department of Health Governance and Financing, who will be providing her perspectives on how this can inform the work, health financing policy work that the department does globally. So I'll begin now by sharing my screen. Unfortunately, you won't be able to see me now after this, but I will. So we have with us 4 speakers. So Mary Bolivar, who is a medical doctor and health policy expert based in Colombia, and her experience combines research projects with hands-on experience designing and managing national health insurance and payment schemes, promoting policies to realize the right to health in Colombia and making progress towards universal health coverage. Then we have Sapna Desai, associate with the Population Council in New Delhi, where her research focuses on women's health and well-being and interventions with women's groups in India. She is a co-lead of a global evidence consortium on women's groups and previously spent several years working with SEWA, a trade union of informal sector women workers, to scale up its community health worker program. Modupe Ogundimu is currently a general manager with Nigeria's National Health Insurance Scheme, where over the past 15 years, she has worked in key operational and technical departments, developing and implementing policies and strategies towards Nigeria's attainment of universal health coverage. And finally, Inka Mathawa from the WHO Department of Health Governance and Financing has over 20 years of experience and leads global work on strategic purchasing for UHC, with an interest in mixed provider payment system and governance arrangements for purchasing and digital technologies for health financing. So we have an exciting set of presentations ahead, and I'll briefly begin by introducing the research program, its motivation, and then handing over to the country presenters. So now to discuss the problematic. So in the last few decades, we've seen several new publicly funded health insurance or insurance type schemes in low and middle income countries. And they often engage the private sector as providers and are seen as key to move towards universal health coverage. We see examples of these in countries such as Ghana, Indonesia, Nigeria, Pakistan, India. And looking at these schemes solely in terms of population coverage doesn't give an accurate picture. UHC, of course, is much more than insurance, and UHC and insurance programs or insurance type programs are more than just coverage. Coverage is an essential part of it, but just having an entitlement or having a card on its own is necessary but not sufficient. And there are several reasons for this, where people who are technically covered may actually not be able to exercise their entitlements. One of these is the lack of information around rules. People may not know about the scheme itself or know how to enroll or how to utilize the scheme. There may be rules and regulations that actually impede people using the scheme. For instance, having administrative rules that are difficult to understand, having certain procedures reserved for public sector hospitals, such as there in some schemes in India, and patients are not aware of that when they go to private hospitals. Power asymmetries, which exist in all these settings, which make it difficult to actually hold providers and insurers to account. And other challenge, all of these challenge the ability of citizens to effectively exercise their entitlements. And what we see is that countries at national and subnational level and civil society initiatives have put in place several initiatives to address this problem. These include initiatives to ease enrollment, be they through technological provision or through providing information about this, information provision, reporting and grievance redressal mechanism, be they through hotlines or desks or offices, a lot of initiatives around navigation or brokerage, having people who actually help the insured access their entitlements, and at the more policy level, involvement in oversight and benefit package design, as well as engagement and participation in the program's management. So we see the picture. So there are these programs and there are these initiatives which have been put in place to allow people to effectively exercise their entitlements. What we found was there was not much research in this area. And to fill this gap, the Alliance worked with the Department of Health Governance and Financing to launch a new research program to examine initiatives to empower citizens to be aware of and effectively exercise their entitlements within the context of these pre-existing health insurance type arrangements. To inform this, we first held a consultation with a wide range of stakeholders, including from national policymakers, civil society groups, and other technical agencies such as the World Bank. We followed this with an open call for research in 2019 and received 69 proposals from around the world. 7 of these proposals are currently being supported under this program that I mentioned the Alliance is carrying out in collaboration with the Department of Health Governance and Financing, with additional technical input from Heidelberg University. And the studies use a wide range of methods. We've encouraged the teams to work on using a range of quantitative and qualitative methods, bringing together these to provide a holistic and rich picture of how these initiatives function and how they've actually helped to allow people to exercise their entitlements. And to aid a common understanding, we worked with the research teams to develop a common conceptual framework to inform the studies. And this was done at a protocol development workshop where we worked with the teams to forge a common understanding of the research program and what we aim to get out of it. So this is just an overview of the studies that have been supported. This demonstrates the heterogeneity of studies supported, both in terms of the settings. So we have studies from Asia, Africa, Latin America, and Europe. The last being represented by Bosnia-Herzegovina. We have a range of mechanisms such as initiatives that are there. As I mentioned, navigators, helplines, mobile phone apps is in Ghana, letters of rights and entitlements is in Colombia, as well as involvement in user associations in Colombia, which you will hear from shortly, as well as in benefit package design. And so this is just an overview of the range of studies supported. I'll quickly go through the 2 frameworks that we did develop. And the aim here is not to actually go into them in depth, but just to give you an idea of what we envisaged when developing this program. So the first part we did is we used this in framework, seek to locate initiatives within the health system. And the aim was to develop a typology of the different initiatives. So initiatives around enrollment, around information provision, around enhancing oversight, enhancing participation, and then link these to the intermediate outcomes and UHC final and health system objectives. So just as an illustrative example, initiatives to facilitate enrollment can function through increasing awareness, through increased financial access, as well as their direct influence increased registration. These in turn would help to improve utilization and access in line with need, which are then in turn important for improved population health status and user satisfaction. So the aim here is very much to locate these initiatives within the larger health system. And this framework, modified from Molyneux et al., really lies at the core of the analytical work that we're supporting in this program. It seeks to understand how these initiatives of accountability lead to responsive health systems. And of course, we here in the middle have the Walton-Gilson policy triangle of the content, context, and process factors. I'll quickly just go through what we mean for each of these. So the content really looks at what is the design of the accountability initiative and how is it supposed to be implemented, looking at things at what level of government does it operate, what its purpose is, whether it's been introduced top down or bottom up. The process goes into understanding how the accountability mechanism is implemented as opposed to how it's supposed to be implemented. So this includes perceptions of various stakeholders and relations among them, such as how officials and citizens view the program, the extent of trust between citizens, for instance, as well as factors related to the direct functioning of the initiative. For instance, how representation is organized, how are decisions actually made as opposed to how they're supposed to be made within these initiatives, what is the social capital within communities. And context here, we look at both macro and micro context. that influence the content of the process. So this includes macro level factors such as the nature of the political system, is the state developmental or not, is the bureaucracy professional, as well as more micro factors, which look at clarity of accountability lines, for instance, inside the health insurance program. So this is just an overview now. 3 country presentations will follow. So these represent a diverse range of settings. They represent a diverse range of actors leading them. So we have the initiative in India, which is civil society led, versus those in Nigeria and Colombia, which are state led. They address health insurance programs of varying maturity. So again, we have Colombia's long-standing insurance program versus newer programs in India and Nigeria, and reflect the diversity in the kinds of initiatives, as you will see from the presentations. And then we'd reflect from the perspective of how this informs health financing policy reform with Inca's presentation, and then open it up to discussion and question answer, including some polls which we'll take from the participants. So thank you very much. And I'd like to hand over to Mary to present from Colombia.
Thank you, Subin. Good morning, good afternoon, and good evening for everyone. It's a pleasure for me, on behalf of my colleague, to present our research project that aim to understand if the mechanisms of participation in Colombian subsidiary regime have been appropriate to engage citizens. Colombia is a Latin American country with 50 million of population. Our health insurance system covering 93% of population, and it has 2 regimes since 1993, and it has a subsidized regime with for poor and informal people, and contributory regime for formal workers and other people with ability to pay. The next one, please. We are studying 3 initiatives for citizen participation and engagement. The first one is letter of right and duty and letter performance that provide information to affiliates. The second one is citizen participation in prioritization process to define the benefit package to the system. And the last one is user association that is conceived as a vehicle to promote patient-centered care and adjusting the local needs. Also improve the accountability, engaging the defense of users with grievance and redressals, and influence the design and operation of the system, taking part in the board of the director. Today, I'm going to present our preliminary findings for this initiative only. However, there are these initiatives, people are not aware of their rights and obligations and not involved in different aspects of insurance design and oversight. Then our study aims to answer whether, to what, or why these 3 initiatives have or not been able to improve awareness, empowerment, and responsiveness in the subsidized regime. The next one, please. Mixed methods needed. We have complex problems, and we aim to understand the why, not only what has happened. There are non-experimental data for causal inference challenge. And then we follow a theory-based evaluation approach where we describe how this initiative impact the outcome, and then we map the different items and levels, the theoretical causal path to primary and secondary data, an indicator to be measured and analyzed. For this, we follow the overarching framework that's being explained in the introduction. And we assess three major factors: content or design factor, process factors, and context factors. The next one, please. We conducted a national representative household survey, and we found that 78% of respondents knew that user association can suggest service chain of the insurance entities. And among people that know of the user association, nearly 1/3 have hands-on contact with them, and 1/5 have participated in association meeting. In the left chart, that represents 10% of respondents now a user association. The most common reason for contacting the user association are related to questions on quality and access service. And 2/3 of people who have had contact with the association believe the interaction was useful. The next one, please. We also conducted an interview with the main categories of stakeholders in the system, and we found that UA is a well-intentioned initiative because gives the user a voice in the health system, but unfortunately its design is rather weak. The main results include the following 5 factors. The first one is that UA don't seek representativeness. For instance, just a plural number of affiliates is 2 or more people. Then interests of the few many differ from the main. Differ from the main. The second one is UA is not mandatory participation or all voluntary. Then the regulation creates a scenario for user participation that will never materialize. Third one, UA don't receive funds and there aren't incentives. Fourth one is not, it don't have teeth. Some affiliates can sit in board of the director only for public insurer. However, user may have trouble getting their voice heard. And last one, UA has no champion because no one seems to be interested in pushing this forward, and regulation has not changed in decades. The next one, please. In conclusion, although 78% of affiliates know the functions of the UA, only 10% know or can identify one, and 2% can take some advantage of them. Then, in summary, first, system-wide, UA seems to contribute too little to empowering affiliates and trigger a system response. Second, yet in the drops that go out to the funnel, there are success histories, but they tend to represent individual interests. Third, the initiative has potential, but design and implementation must be strengthened. And definitively, UA need a champion, fit, a strong promotion, funding, and incentive. Thank you very much.
Shall I begin?
Yes, please.
Okay, great. So good evening, everyone, and thanks so much for being here. I'm going to present some information and preliminary findings from an implementation research study that the Population Council in India has done in partnership with the Self-Employed Women's Association, SEWA, which is a trade union in Gujarat. Next slide, please. So we conducted this study, or we're conducting it in the Indian state of Gujarat, which is in Western India. It's an approximate population of 60 million, where as of the last National Health Survey, which was a few years back, about 1/4 of people reported being covered by some form of health insurance. In the state, and as Zubin mentioned, in India, we have a recent national health insurance scheme called the Prime Minister's Jan Arogya Yojana, or PMJY for short, which had a predecessor as well, which was a different national scheme. And at the state level, there's also one state level scheme that also seeks to address catastrophic health expenditure for primarily hospital admission, but also select outpatient procedures. So the challenges in India, and this is not unique to India by any measure, are similar to what Zubin mentioned earlier: low awareness around schemes. In general, we've seen in research across the country, continued out-of-pocket expenditure by beneficiaries, and difficult procedures in particular. So the paperwork involved in trying to navigate processes both before utilization and during utilization are what on the ground we've seen as the primary challenge really to equitable and better use of these schemes. So SEWA introduced in response to this something called the SEWA Shakti Kendras, or community-based navigation centers. Next slide, please. So what the SSKs are for short is, first, they were introduced by an organization that has been around since 1972. It is a large, probably the largest organization of women workers in the informal economy. Right now, about 2 million members in the country across several states. SEWA works towards a range of areas to improve women's self-reliance and full employment, such as microfinance, livelihoods, social security, which includes health, childcare, and also health insurance. It has its own community. All sorts of entitlements. So not just health insurance, but also, let's say, pensions, childcare, etc. SEWA started these centers called the SSKs, the SEWA Shakti Kendras, which are community-based resource centers staffed by local women in the community. Now, just for context, the government, in response to many of the challenges with previous health insurance schemes, has introduced design innovations like automatic registration. So people are informed by a letter or a card arriving at home that they are registered under a scheme. There are facilitators within hospitals. There's also technology-enabled enrollment, as well as grievance redressal mechanisms. Next slide, please. So the SSKs work on multiple levels. So the first thing the centers do is they facilitate enrollment by really helping women and households navigate the really difficult paperwork, registration procedures, and cards, particularly for people who didn't receive it, which we hope aims towards increased registration. Secondly, and at the core of their activities, is really around information and education, both around entitlements as well as health issues in general. The next area of work is around facilitating access and utilization. So for example, they hold health camps in communities to raise awareness about undetected health issues, as well as conduct exposure visits, which is quite unique, to hospitals and to government offices to sort of help people in advance understand how to navigate what can be often complicated procedures. The last is informal engagement with the scheme. Because there's no formal community engagement mechanism in India, SEWA has innovated with informal mechanisms like community meetings in which local government representatives are called, individual feedback meetings where they go to meet officials in charge to really, have a sense of rapport and also feedback from both sides. And this aims to enhance citizen involvement informally for insurance, but also more formally through the public health system where there are mechanisms. So what we see through this, while the programs work to strengthen primary healthcare delivery on the side, we hope that these work together, and that's SEWA's aim, to increase utilization also access in line with need, as well as, though not a primary purpose, but improving health services together. And that is at the heart of this initiative, where public health and health insurance are seen together, as opposed to just looking at the insurance scheme in isolation. Next slide, please. So our research questions are really around how the SSKs work. So in an implementation research approach, we're examining the content of the intervention, the context with which it's implemented, including the micro context of different centers and the implementation processes, to identify what factors specific to implementation are associated with improving awareness and, if possible, utilization, and also looking at factors that may vary across different sites, particularly rural and urban sites. So what we've learned thus far from not just processes, but also the content and context, is that having this local one-stop center has been incredibly important from the point of view of both implementers and community members, because the center doesn't only deal with health insurance, it also provides support with basic documents and also health information. So again, an integrated one window approach. There's also last mile delivery to the household, because these centers are staffed by community health workers who already are roaming the community and know the community. The approach towards building capabilities is quite unique, and SEWA has, at least from their perspective, seen this as to be a great enabler of the work, because it's not just functioning as an agent, but also building people's trust that they can help them navigate and eventually gain the skills through things like exposure visits. And lastly, and probably most importantly, is that SEWA has a very long-standing presence in the community, which has facilitated government engagement. This approach isn't without challenges, of course. From the point of view of the community, low awareness of the actual benefits involved, which can be complicated, remains a challenge. On the supply side, and this is really where the bulk of challenges are, issues around who's eligible, because these are linked to poverty assessments, and it's not something civil society can address easily, at least, though it's not impossible. We've seen a lot of responses around preferred hospitals not being covered because of the large number of private hospitals, for example. The ones that women may prefer or members and households prefer may not be covered under this specific scheme. And also the complicated processes that persist for individuals, but also for the SSK staff, because it's quite time intensive to help women navigate. One thing we did learn, though, and I think one of the power of these centers going beyond helping people navigate the system is their adaptability. Because it's not only a health insurance center, it is an overall kind of empowerment center, so to speak. When COVID and COVID-induced lockdown struck in March, they quickly shifted their work, because most hospitals were anyway not taking non-COVID patients and there was a crisis at hand. They shifted to digital communication, for example. They also expanded their services, so there were linkages between the government and health workers to help deliver COVID-related benefits, as opposed to only focusing on insurance or other schemes. One learning, though, however, as helpful as that was, is that the digital, and this was the first time SEWA's really tried this in depth, that working only on the phone was just not a replacement for one-to-one contact, even if there was a long-standing relationship in the community, and particularly not with government, because picking up the phone to call an official versus actually meeting them, as we can imagine, are very different. So I'm going to wrap up with some reflections from what we've learned through the research and also coming from implementers. So I think most importantly, these centers, what has influenced how the ones that have seemed to work effectively is the abilities of the health worker who staffs them. So the ability to navigate the system, to have pre-existing trust, to be able to reach multiple levels. So going beyond insurance from the point of view of the community, but also being able to work from the grassroots up to government functionaries is quite unique. From the other side, of course, responsiveness of the government is a great enabler when it has worked, and the availability of services. Something SEWA's often asked, and as researchers we ask, is, well, what about the scalability? This is being implemented in a set geography as of now. So this approach, and this approach to community empowerment and engagement, does require some level of either pre-existing or investment in building community level leadership. Now, that's been done in many different ways, and it doesn't require only an NGO such as SEWA, but there are different models, for example, local governance in India. The one unique feature that may actually pose a barrier to scale or perhaps facilitate scale, depending on how it's seen, is the multi-sectoral approach. The fact that this isn't just health insurance means that whoever is operating those centers works across many different schemes, which is, as I mentioned earlier, a great strength. And lastly, and I'd really like to close with emphasizing that empowerment is intentional. You see a lot of agents who will ensure, or even civil society agents who ensure access to entitlement, often for payment or not, but it's the idea of the last mile delivery of just getting that entitlement delivered. Whereas this approach is really around information, but building capabilities. So ensuring that people, through things like exposure visits and direct engagement with the government, have the capability to continue applying that sense of entitlement, accountability, and engagement well beyond that immediate need for a specific entitlement. And that extends itself also to those who work in the system. So being part of an organization, for example, the incentives go far beyond payment, whether it's scheme-based or salary, but rather building a community-based approach to accountability, really. So I'll close there, and thank you very much. And our information's here for anyone who's interested.
Thank you, Sapna, for this very interesting presentation. I'd like to invite Modupe now to present from Nigeria.
Right, so I'm on. Okay, good morning, good afternoon, good evening. I'm Modupe Ogundimu. I'm from Nigeria. I'm here to present the responsiveness and beneficiary empowerment, an assessment of the accountability initiatives in the Nigerian health insurance programs. Next slide, please. So Nigeria is quite a large nation. It's, by today's figures, it's over 200 million. We have a population growth rate of about 2.6%, and we have a health insurance coverage which is abysmally low of 5%. And so we have, for our research work, we have our data sources as healthcare facilities, our NHIS offices, our central government offices, and our community premises of our community organizations. Our problem statement basically is beneficiaries are unable to navigate our accountability initiatives as they should in the health insurance system. Our research objectives and questions are the main aim of the research is to assess the contribution of accountability initiatives and institutional arrangements set up by the scheme in order to empower beneficiaries in the different health insurance programs. We have questions and objectives such as the contribution of our NHIS central government desk officers and healthcare desk officers in beneficiary awareness of entitlements in our formal sector programs, the role of our NHIS customer care centers and our subnational offices in grievance redressal in both the formal and informal sectors, and the role of civil society organizations or board of trustees of our mutual health associations in the design and participation of health insurance in the community space. So these are our data sources and methods. We carried out focus group discussions with beneficiaries in our communities, that's beneficiaries of our community-based health insurance programs. We held key informant interviews with the board of trustees of these community-based health insurance programs, our NHIS administrators, our NHIS and central government desk officers. We also carried out surveys with the public sector beneficiaries. And finally, we carried out a document review of our call center logs and our grievance redressal systems in the subnational offices. So why were these initiatives set up? So we have the 4 accountability initiatives here, and for the desk officers, the reason why they were set up was to ensure that the beneficiaries could actually navigate the health insurance space on their own with help from these various people in the central government and in the offices and in the health centers. Also, for the subnational offices, there was poor awareness of health insurance outside the capital city, and there was no beneficiaries actually had no physical contact with the scheme. And also, Nigeria, being that it operates a centralized health system, we needed to actually have these initiatives closer to the people. Then the customer care center was set up because there seemed to be a communication gap between the scheme's beneficiaries and healthcare facilities and other stakeholders, and also the beneficiaries were unable to properly seek redress. We also had issues in the communities whereby the kick-off programs of health insurance in Nigeria, there were also poor awareness of their health insurance benefits. Next, please. So what's really influenced the design of these initiatives? As I said, for the desk officers, it was basically poor service delivery as reported. There was need for on-the-spot resolution of complaints and service failures as obtained in other sectors such as the telecom and banking industries. The subnational offices, there also needed to be prompt service provision and grievance redressal as stipulated by Nigeria's service provision network called Service Compact, watchdog, called Service Compact. There's also a need to bring health insurance closer to the people due to the decentralized health system and also the provisions of the National Health Act of 2014. In the customer care center, we also had poor service delivery by complaints of poor service delivery, and there needed to be easier communication channels between the scheme and its stakeholders as stipulated again by the service provision watchdog. Now for the community programs, our kickoff programs in NHIS did not actually involve the community because funding was just for central government beneficiaries. And however, between 2008 and 2015, we actually had an intervention by the Millennium Development Goals, and this was successful in 12 communities in 12 states of Nigeria. So we thought this would be something that should actually be continued. Right, so how do we think these initiatives can be improved? One of the things that we think is that for desk officers, both in the central government and the healthcare facilities, that there should be training and retraining on how to actually promote awareness and grievance redressal and how to carry out redress, to have regular stakeholder engagements between the beneficiaries and also the hospitals and every other stakeholder in the space, and also to establish a award system for excellence, especially among the desk officers in the central government agencies. For the customer call center, we feel that there needs to be an improvement in the infrastructure, including the provision of toll-free lines so that people can seamlessly get in touch with the scheme without having to think of the cost of making the call. We also need to improve awareness and communication on the functionality of the customer care center itself. In the subnational offices, we need to increase the awareness of its functionality, to train and retrain the staff of these offices so that they are more responsive to the needs of the beneficiaries, to actually establish a health information management system which will ensure seamless enrollment, grievance redressal, and quality assurance in that space. And for our community-based programs, we feel that we should ensure that the program managers, which the Board of Trustees and the civil society organizations are adequately trained to provide the capacity needed to serve as program managers. We also feel that the scheme needs to do more in giving technical supports so that they can actually deliver the good governance and provide strategic oversight and direction in these programs so that the people are more aware and interested in enrolling in the programs. You jump one slide. So in conclusion, we actually haven't completed the study, but it's hoped that the study outcomes will actually assist our scheme, the National Health Insurance Scheme, to improve accountability initiatives and thereby empowering the beneficiaries and also transforming this scheme into a more responsive organization in providing financial access, quality healthcare, and ultimately improving its contribution to ensuring that Nigeria attains universal health coverage. Thank you very much.
Thank you, Modupe. Now we have Inka Matawa to present on the implications of this work for health financing policy. We come to the end of our 3 research teams presentations, and Inka will provide a global overview. Over to you, Inka.
Thank you. So hello, good morning and good afternoon. It's a pleasure to be here with you. I will present and briefly synthesize the findings on the accountability initiatives and their weaknesses with respect to empowering citizens and making health insurance schemes more responsive in the 7 country studies. And based on that, I will share some reflections on the implications and the options for health financing policy. Just a little note on the side. Obviously, what we're talking about is equally applicable to more generally to health coverage schemes. The research program has been specifically on health insurance type schemes, but this is also relevant for other health coverage schemes. Next one, please. So here I have just listed again all the forms of accountability initiatives under study. So many of them are government-led accountability initiatives, but several of them also led or taken on by non-governmental actors or groups, especially the brokerage and the navigation. But also, for example, the support to participation in stakeholder meetings, as well as the engagement, the negotiation, and the advocacy. Next one, please. So how well do these accountability initiatives function in the 7 study countries? And so I think what we see is in this ongoing research that some of these initiatives, accountability initiatives, and largely the government-led initiatives are weak and often do not achieve their objectives. In fact, where the government or the health insurance navigator mechanisms do not work well, other actors, such as NGOs or health workers or individual health workers or informal groups, have taken up this role. So I think this is a very important finding in this research across several countries. Also, what I find very interesting is that few countries actually have participation mechanisms that really enable people to influence the policy and the program design. So looking at the causes for these weaknesses, what is it that we see? There are weaknesses first on the design side of these accountability initiatives. So for example, they would provide information and collect feedback, but actually these accountability initiatives do not really give people sufficient agency and voice. So the effect on empowerment and responsiveness is limited. And then there are causes of these weaknesses on the implementation side, which is often incomplete or insufficient. So for example, that's due to inadequate staff numbers or inappropriate profiles of staff in these various accountability initiatives, for example, navigation or providing information. Sorry, just one back again. There's also inadequate awareness about these mechanisms from the side of people or lack of trust. Next one, please. So the implication here is that health financing policymakers need to take these findings into account when designing or specifically when improving the accountability initiatives so as to improve responsiveness and to strengthen the empowerment of citizens. So what could that actually imply? Can we go to the next one? So here I'm sharing some reflections about options, and this is really ongoing and we're further developing this thinking. But one aspect is with respect to strengthening the accessibility, the availability, and the functionality of information provision, reporting, and grievance challenges. Also, it will be important to clarify and simplify the actual entry points to access services. So it should develop into a healthcare system that is easy to navigate. Also very important related thereto is to have sufficient numbers of navigators that can be reached prior to seeking care, as well as at, the point of use. I think we have heard that from the India case, but it's also relevant in other countries where this research is going on, such as in Indonesia. And last but not least, there is need to clarify the entitlements and the benefits so that it's clear to the users. And this should be done through, simple messages through various communication channels, as possibly through, social media as well. Next slide, please. Now, how can citizen empowerment be strengthened, in particularly that one of vulnerable population groups? And I think a first work stream here is about strengthening user and citizen participation in scheme decision processes in committees and oversight bodies. So this would mean to have a seat, one seat or ideally several seats for users and citizens to represent different population groups, including those from the informal economy, and also to have transparent processes of selecting those representatives. And clearly this would go beyond the traditional tripartite representation that we often find in health insurance schemes, where you have government, employers, and trade unions as the key representatives in oversight boards. However, you wouldn't have other population groups covered there. So this is really going in that direction and opening the seats and in the space, so to say, in these various bodies or committees. Second, I think what we have seen, for example, in Colombia, really learning from there is that, there's need for organizational support to make user associations more functional. And last but not least, people need to be informed about these opportunities that are there, these accountability initiatives, and their use should be facilitated. So there should be some support to people that they can actually, and that they do speak up in these various committees or decision-making bodies. Next one. And then I think the second work stream with respect to strengthening citizen empowerment is to invest in transparency and trust building measures. So people need to be encouraged to use the accountability initiatives that are available. So if we take the example of Colombia, there are these user associations. There are mandated by state, but actually, the majority of people don't really know about them or don't use them. So how can people actually, get involved into that? I think we come back to sort of a need and a request that is so old, but it's still, is so relevant. Public reporting by these health coverage schemes about their performance, about their plans, about what they have achieved and what they haven't achieved, and really sort of have, a self-critical presentation of where they are. And last, I'm wondering to what extent the use of digital technologies can actually help to increase transparency. And I think this is maybe also something coming out, throughout this year with the COVID pandemic, where, communication has changed. So in order to ensure that all users actually have access, let's say, to committee minutes, could digital format actually be an option? Or, having once in a while virtual meetings so as to reduce the transport and the opportunity costs. Next slide, please. So let me come to my two final slides on conclusions. I think what we see is that, it will be difficult to improve on the UHC objectives without policy measures that empower users so that they can actually make use of their entitlements, and also measures to improve the responsiveness of health coverage programs. Both the findings that we have heard from the 3 country presentations and beyond in the other 4 country studies, as well as in the options that I have just shared. I think this suggests that governance arrangements have to be put at the center of health financing policy agenda, or at least has to get much more attention. And I think related thereto, these proposed options would call for a mind shift among health insurance organizations. It's really about establishing a learning culture. So it should become normal to, and very self-evident to be open to listen to feedback from citizens, getting their reports, getting their grievances, and considering that as being useful. I wonder to what extent then more advocacy is needed to make the case for citizen empowerment. Yes, first of all, of course, it's instrumental for better health, but also it's intrinsically good that people are at the center. And next slide, please. So I think we do see that effective accountability initiatives should and must ultimately lead to UHC-oriented health coverage programs. But I just want to remind us as well that on their own, these accountability initiatives will not be enough. Ultimately, the design features of health coverage schemes must be based on sound health financing principles. And we do know quite a lot of what works and what doesn't for UHC. And when I say we, I actually mean, you know, the country policy experts together with the global community. So here I have listed a couple of health financing principles and design features. And I'm not going to read them out, but just to say that ultimately, there's no way around them. We need both. We need well-functioning accountability initiatives, but coupled with, you know, the application of sound health financing principles. And with that next one, I thank you very much for your attention. And we look forward to getting your questions or comments. There is the live Q&A part, and yes, there are already 2 questions in there, but I'm handing over to Zubin.
So thank you very much, Inka, and to all the presenters for these extremely interesting and rich presentations. We saw the diversity of programs supported by this. We saw schemes such as in Colombia involving the use of user associations. We saw the work of navigators in India and the whole plethora of schemes that are included in Nigeria's health insurance program. And then Inka's point about how accountability is both intrinsically important as well as instrumentally important for health financing schemes, but don't forget the fact that sound health financing policy needs the technical design of the program to also be in place along the accountability mechanisms to function well while developing and designing these universal health coverage schemes. So with that, we'd like to now first go to our polling and engage the audience in the polling. And you have 3 polling questions. Actually, there are 2 polling questions and 1 question which we'd like you to discuss through the chat. So through the chat function, could you give us an example of an accountability initiative in place in your country? It would be great to have inputs from the audience on a similar or different accountability initiatives within your setting. And while we're doing that, and while we're getting your responses, there are 2 polling questions. I'll first read them out and then start the poll. So first question is, in your opinion, how responsive is the public health insurance scheme or health coverage scheme in your country? And you'll have 5 options: not or hardly responsive. So these are all on the portal. Low responsiveness, somewhat responsive, generally responsive, and very responsive. And the second polling question is, in your view, how can accountability initiatives be made more responsive? And here also we have 5 different options. I'll begin with the first one. And we'll have about 30 seconds for answers from the audience. I'll just begin this. So in your opinion, how responsive is the public health insurance scheme or health coverage scheme in your country? All right, it's 30 seconds. And we see that 63% of people say that this is their schemes are somewhat responsive, 13% each low responsive, generally responsive, and very responsive. So we see reflecting some of the cross-cutting findings that Inka put, that responsivity is, schemes are there in place and they seem to be somewhat responsive, though their effectiveness could be improved. And now coming to the second question. In your view, how can accountability initiatives be made more responsive? And we have 5 options here: changing the mindset, willingness to consider feedback and grievances. And this comes to the changes in the public sector's attitude towards engaging beneficiaries and the role of the public sector relative to the beneficiaries in terms of a service mindset. Better design in providing more space for participation. We did see that beneficiaries tend to be, most of the schemes focus on information provision with relatively little scope for participation in user associations. Better implementation. We saw, for example, in Nigeria that Modupe pointed out that is a challenge, having enough support and staff. And making the initiative better known, informing people about their existence, as well as another question which allows you to write in your answers. Sorry, I don't know if it allows you to write in your answers, but you would then, yeah, it would allow you to write. And so please explain. So I'm beginning this here, and in 30 seconds, please share the results. So we see from the results here that a third of people, the single largest group, feel that better design and providing more space for participation, giving more agency to people is the most important way to make up accountability initiatives more responsive. This is followed by the emphasis given to information provision, making people know about their existence. And 17% each have voted for changing mindset of public officials, as well as better implementation. So we see a mixed range of responses, with the greatest emphasis on better design. So I haven't seen too many questions in the chat box or response in the chat box around the different accountability initiatives that exist in your country. So we'll go on then to questions to the speakers. So the first question is to Inka. And the question to her is, what is the role of accountability in health insurance, health coverage schemes, and how is it taken up in health financing policies? So if you could address that, Inka, that would be great.
Yes, thanks very much for this very important and very good question. Now, so where does accountability stand in health financing policy? And I think the first important thing to say is that accountability or transparency is actually part of the UHC intermediate objectives. So we have efficiency and equitable distribution of resources, and then transparency as the third intermediate one. And that's quite important because it does say that we need that this is conducive to achieve the final UHC objectives. And also the issue of maybe more broadly, governance has received increased attention in health financing policy over the years. Last year, for example, we published an analytical framework to assess the governance arrangements for strategic purchasing at country level. And of course, accountability really features in there. So, you know, we're looking at, so this governance framework looks at, you know, the overall health system level, as well as at the agency level. So how are individual purchasing agencies being governed? So like a health insurance scheme. And so, of course, participation and accountability features well in there, you know, making the case that, you know, it should go beyond tripartite representation and you know, broader civil society needs to be represented in there. But I think what this research here really shows us is that, you know, we assume that it's there, but does it really work? That's the other question. And I think these 7 country studies show actually that, you know, the real participation is not really so widespread. They're not really available or don't work well. And so as we think, you know, there's a good health coverage scheme because it subsidizes people, because, you know, there's targeting, you know, there are differentiated cost sharing rules, etc. But still people don't benefit and don't get adequate access because they don't know about it. So in that sense, that's where really accountability and responsiveness has to come in. What does it mean to be responsive as a health coverage scheme? It means the ability to be responsive and the existence and offering, the functional accountability initiatives, to have them in place so as to hear people's voices, to take up their feedback and to accept their grievances. It's what I briefly hinted to in my presentation. It's about establishing a learning culture and really putting people at the center. And this doesn't require major changes that have to take place at the parliamentarian level. Often these are changes in the rules and procedures when it comes to being more responsive, making enrollment procedures less complex, helping people to navigate. These are small changes in terms of the actual daily practice. So maybe just one final sentence. I think in health financing policy, we do have to pay much more attention to accountability initiatives and ensure that they work, that they function the way they're supposed to achieve what is intended. I think this maybe does somehow also respond to the first question in the live Q&A. Thank you.
Thank you, Inka. And I'd like to now pose a question to Sapna. So this is related to the fact of SEWA as a trade union of informal sector workers, and it plays both a strong advocacy role and has close relationships with the government in doing this as well. And I'd like to know how this sort of role of engagement and being an advocate, which puts you in natural, not confrontation, but there are opposite interests to certain government officials in terms of the way in which you engage, how that actually influences the way in which the SSKs have been designed and their day-to-day functioning.
Thanks, Subin. That's a great question, and one a lot of people ask, I think, when they come to see the model. So from the point of view of advantages, I'll start with SEWA as a very long-standing, established civil society organization. So it has a level of credibility, but also community outreach and numbers. So they've been able to leverage that, for example, in very concrete examples, sharing space with local government offices, for example, to house the SSK, which is quite unique. So the local decentralized governments we have in India using one of those rooms, for example, in the village. Secondly, they've been able to, let's say, aggregate lots of applications for different schemes together and then bring them all at once to a government officer, which is not something that normally happens. It's usually this one after another, one person navigating. But as soon as you aggregate, there's a sense of accountability almost immediately from the other side. And third, and really importantly, I think it's not done this in a, how does one say, it's not been antagonistic in the sense of only monitoring and accountability, but also a long history of trying to find solutions. So for example, when schemes weren't being filled out properly, trying to figure out solutions to help individuals or even changing the forms, for example. So that, and another one, transportation has been a real barrier, and we see this around the world. So actually bringing registration camps to the village in partnership with the government. And this hasn't been done just for insurance, but also for health camps, for example. So, that model of bringing services to the people is something that also helps the government, as long as there's an organization that can facilitate the attendance and the participation. So those are the things that I think have been a real advantage. I think we have a lot of examples in the health system in India and within public health around community monitoring and accountability. They're newer in health insurance, but I think following those models, there are examples of how local organizations, and not just SEWA, but local organizations, including local government representatives, have been able to work in partnership for scheme delivery in particular. I think where SEWA goes beyond is that empowerment approach, like I mentioned, of building the capabilities of people, which could be threatening in a sense as well, but building the capabilities of people to actually navigate systems. You're on mute.
Thank you very much. I'd like to invite Inka to manage the moderation for the next part. Thanks very much, Inka.
Thanks. Yes, so we have two questions so far in the live Q&A from Ariel Frisanjo. Very interesting questions. So the first one is that, he's pointing to the unequal power relations within the community. So between those who are most excluded and then maybe those who actually participate and take decisions. So how can actually this challenge be addressed? How can the most excluded also be heard? How can that be overcome? And I would suggest we address this question maybe to our colleague from Nigeria, to Modube.
Yep, so one of the main challenges that we face in the health insurance space is actually a lack of continuity of policy directives on these accountability initiatives once there's a change in leadership. And that has actually prolonged the way in which the accountability initiatives could actually be properly formulated, because when you have a change in leadership either at the top echelon of the health sector or even within the scheme, then there's sort of a shift towards what actually would be that should be continued and what should be put aside. So we're hoping that with this study, things like that will change. There will be some sort of process in place to actually ascertain that these things should be continued irrespective of what the leadership in the organization. The other thing that we've noticed is that there is a communication gap between the scheme, the beneficiaries, and the stakeholders about what these accountability initiatives actually are, what they serve to do, and the benefits they are to the beneficiaries of these. So technically, the beneficiaries are not sufficiently empowered to actually assert what their entitlements should be at the point of care. So we're hoping that we will be able to improve on communication through different channels and ultimately have a proper ICT infrastructure that can actually ensure that this is done seamlessly.
Thank you for that. In the interest of time, I suggest that we take the second question, and then I hand over to Subin again. So the other question also was from Ariel, and it was actually addressed to me, but I suggest, we all come in. So basically, Ariel asked, so when, let's say, in the case he gives here the World Bank, but I think we can also refer this to other partner organizations. When partner organizations support the implementation of health insurance, he asks, should such programs actually have a component on strengthening accountability? And should that be a sine qua non assessment criteria for program success? Let me be very brief in the interest of time, because we want to give the chance to the other speakers as well. But on the first part, I would certainly say from what we learned here in this, from this research, is that yes, much more focus, as I had said, should be put on accountability initiatives. So actually how to strengthen them, how to support them, how to improve them, that should definitely be there. Should that be a sine qua non assessment criteria for program success? Well, maybe I would suggest to leave that to each and every organizations of how they organize their, performance monitoring, their program monitoring. But certainly it should be assessed, it should be measured. Whether it's, your sine qua non assessment, that's maybe another question for yourself, maybe to see. I don't know whether anybody else wants to add or complement.
So thank you very much. That's an excellent question. I think having this, as we've seen from the research, a lot of the accountability initiatives can be put in rather formalistically. They can exist there on paper, and then we've seen that their actual effectiveness is sometimes not up to what they're either designed to do, or they're designed in a way in which that they're rather narrow in their scope and they're tokenistic. So in that sense, having developing indicators for this and actually having programs and making this part of larger scale programs would be one step, I think, that would take us closer to it, towards actually having accountable systems. And I said, if you are seriously interested in putting people at the center of health systems, as international agencies, all of us are, and we do talk about people at the center of our health systems, putting these sort of accountability initiatives as a central part of the projects supported would be one way of at least moving towards that. So I would largely agree. Again, I don't think it can be made essential, but I think we'd encourage that based on the findings we've got here. If any other colleagues want to come in on this.
If I could just add one thing, I think in addition to accountability, but thinking about just methods for engagement, I think it's interesting looking at other countries where there actually is a formal mechanism to engage, not just grievance redressal, but also being able to engage with those who are designing schemes. And that doesn't exist in India, for example. So accountability should be seen in that broader light of accountability and engagement.
Do you continue, Zubin?
Sure.
On the
So I'll just pose the remaining questions for the two panelists. So to Mary from Colombia, the question we have is, why do you think that the user associations are functioning as they are, and what do you think can be actually done to strengthen them and improve their functioning? You see that you've got this funnel, and you saw that people are not aware enough of them. So what do you suggest are ways? These are long-standing insurance programs and long-standing mechanisms. How do you actually improve them in practice?
Thank you, Sven, for an interesting question. I think that user association tend to represent individual interests more than collective one. Then it's important to promote a greater participation and improve information and communication strategies for results and for benefit of the user association, and to promote patient-centered care in all the system. This is an important factor. The second one, I think that the capacity to affect healthcare decision making limited. For example, the participation in the boards of directors is only in the public insurer that are a minority group of the population, then it should be mandatory for all insurer company. And other factor is that it's important that Inc. to evaluate and surveillance the responsiveness of the insurer related with the manage of the user association. Other challenges is the most user association are integrated for older people, for seniors, and it's important generational change for this. There are other factors that are in the interviews is the violence in our country, because maybe young people has fear of this participation, then we are going to explore in the focus group. And the last one is the lack of a feeling empowerment among user association. I think that this important and is necessary a budget and innovate model for the allocation of youth recruits, not for salary for the user association, but for the former, the user association member, to bring or to promote better information to all people. Thank you.
Thank you very much. We're really running out of time, so I would like to invite Inka to wrap up. Inka, you're on mute.
Yes. Okay. So yeah, let's come to an end. Let me wrap up. I think this has been a really interesting session. Certainly, personally, I have learned a lot from those 3 country studies and also from the 4 other studies. So let me share a few key take-home messages. I think in terms of the research itself, I mean, this is a health systems research symposium. I think first what we learn and what we see and get confirmed is that research in this area needs to use a very wide range of approaches and methods, as the kinds of accountability initiatives are quite diverse, and so are the agencies, the entities that actually implement them. For example, Indonesia, it hasn't been presented here, but in Indonesia, some of the NGOs that come in as navigators, they are not at all formalized. They operate through WhatsApp groups. It's quite interesting. So, you know, their filing and their sharing of how to go about a certain patient case is all done via WhatsApp. And so how can that actually be assessed? How can one get to that data and analyze it? And that's very different from the nature of the initiatives in Colombia, which are all mandated by states, so they're, you know, very formalized. But overall, I think what we have seen in these 7 country studies is that you need a mixed and multi-method approach. Second, in terms of the actual findings, this research has revealed that what we often take for granted, you know, people are eligible for subsidization, people are entitled to benefit package, that actually really doesn't mean in practice that people really have access and that they really enjoy financial protection. And so the research reveals the numerous, you know, small and also bigger hurdles, but many hurdles that, you know, especially low income people encounter when they seek healthcare. And so that's very, very important now for health financing policy analysis to take into account in health financing reforms. And third and finally, as I said, you know, effective accountability initiatives are needed and they should lead. I mean, this is the assumption, they lead to more responsive health coverage schemes so that these can then react, they can adjust, they can refine their design features. But we always have to keep in mind on their own, the accountability initiatives are not enough. I mean, they're important, but they're not enough. And ultimately the design features of the health coverage schemes must be based on sound health financing principles. So what I want to say is, you know, let's not wait until people don't get access and report and, you know, raise their grievances, you know, to find out what's wrong. Let's have some more proactiveness in that. Health insurance managers, health policymakers need to, you know, preempt and anticipate, you know, what are the problems, and then, you know, apply the evidence about UHC conducive design features. So in conclusion, you know, in combination, when we have a combination of, you know, well-functioning accountability initiatives, as well as, you know, sound health financing principles being applied, I think that's hopefully the way towards accelerated progress towards universal health coverage. I'll stop here. I would like to thank very much the speakers, the country speakers, for their really great presentations. Thank you so much. And also a big thank you to the participants, to your involvement, for your questions, for the chat in the discussion forum, for the polling. Thank you very much. Do stay in contact with us if you wish for further exchange. That would be really appreciated. And so thank you very much. All the best. Take care.
Thank you very much. Thank you for your participation. Thank you, Inka, for your inputs, and to the country teams and to participants for taking time out on a weekday afternoon, for many of you, evening, and for joining this session. Thank you, and we hope to hear from you and see you again sometime soon. Bye-bye.